Thank you, Mr. Chairman. MSTK, are you still there? So if you look back to the history from 2004 to 8, mostly the paper come up with the pro on the MS. And then 2008 to 12, a lot of con article. And then 2012 onwards, it become to the middle of the pendulum. So the answer, I would say yes. But because of many patients, they like the smaller incision, and also many surgeons also like this procedure become different from the others. So anyway, I think some claims of the MAS, some are facts, but some are not true. So let's see. How about some are facts? If we look back to the principle of knee surgery, I would say the basic principle, even though MAS or standard, they are the same. Alignment restoration, bone cut, ligament balancing, and the prosthesis. But in the past 15 years, what is true is that the shorter skin incision, and if the patient get a happy outcome, there could be a very good balancing among three major contributing factors, including surgical technique, anesthesia, and post-operative rehabilitation protocol. And again, everyone needs to practice. They need to pass at least more than 50 cases to have a very good learning curve. And when you are in the steady phase, so you can control your OR time. And again, every time when we do MS, we can do any kind of approaches, but make sure that when your skin is not enough, they become with the U side, you need to change, you need to extend to be a V side, and sometimes the arthrotomy is not enough, so you can do some progressive capsular incision to make the procedure easier. If you look back to a lot of literature have said that there are so many techniques regarding the MS, I would say that there are 4 MS surgical principles. Let's see where it is. The first one, you need to concern about the mobile skin window. Together with the second one, the multiple knee flexion angle. So when you do both, you're going to find that a better visualization can happen even though you have a very limited skin incision. And then you do the patellar subluxation study have shown that it can reduce the prolonged quadriceps dysfunction and decrease the quadriceps tension. And when you do the patellar subluxation, you can enhance the subluxation by put the knee in the deep flexion during you turn on the tourniquet. And also you can do excision of the patellar fat pad that can visualize the lateral side of the tibia better. And again, you need to get a facilitating instrument. And this kind of slim instrument can provide you a very successful surgery in very limited space. But when you think about the left flexing system of the femur, I would say the anterior left flexing system seems to be better. And again, if you think about the rotation of the femoral component, even though the study have shown that the lateral epicondyle is very easy to find in the standard, but in the MAS, you would find that the patella going to block the palpation of the lateral epicondyle. So I think it should be fixed angle of rotation seems to be better. And this is the current meta-analysis about the good result of the MSTKA. You can see that the only thing different from standard is just a shorter skin incision. And another thing is just to provide greater knee flexion at the early follow-up. Just only 2 things that happen. How about some that is not true? Let's see. You see that the previous literature tried to say that it is a minimal resection of bone. I would say that's wrong because you need to cut the bone in the same way. You need to put in the prosthesis in the old-fashioned. And again, they say that the minimal interruption of the nerve tissue and also the vascular supply of the knee region. Again, I would say that's wrong because most of the time you would damage one of the major sensory nerve. That is the infrapatellar branch of the saphenous nerve. And this is the common complication happen to all single patients, even though MS or standard. And we did the study on this injury to the nerve, and we find that even though you do the standard or the MAS, you get the same area of skin numbness, and both groups gonna gradually improve within the times. And we also did the cadaveric study. The infrapatellar branch never come up above the patella. So even though MS or standard, again the same, they get the same area of numbness. And the other thing is less pain. The less pain actually because they say that it might simulate less nociceptor and cause some less inflammation, but actually in fact it's the same. And you can see that in the current term, a lot of modification of the anesthesia and pain control have been changed. We moved to the peripheral nerve block. We found it better than systemic analgesia. And we go to the local infiltration analgesia combined with the other thing of multimodal. So this thing can make the patient ambulate faster. So come to the term of the early ambulation. In the past, MS say that they provide early ambulation to the patient. But when you look at the many studies, even though they say that the MAS, but the key features is that they need to provide a very comprehensive perioperative management pathway for the patient after surgery. And then you need to understand the subacute knee pain after knee replacement. Mostly these patients get a very well clinical improvement, but they cannot explain why after 6 weeks, this patient develop a very painful knee, and they look a very decent X-ray, and also they relate with the too much daily activities. So I would say our strategy, we need to address the subacute pain after the replacement by doing the balancing of the post-op activity and the pain control. And we need to acknowledge the post-operative inflammation and subacute pain. And we need to control limb swelling. And again, we need to accept that we damage the nerve, and we need to address the neuropathic pain. So pain, you want to control pain, address narcotics is good, but pain at motion, you need to go to the NSAID. This is the thing why we put on the NSAID to the patient for longer term. And then knee inflammation, even though MAS, you can see that the indirect evaluation in terms of ESR and surface temperature is high, even though 6 months later. And even though you try to retain the synovial tissue or not, the inflammation is still the same. And again, knee swelling, you know that it causes a lot of problem to the patient. It aggravates a lot of things, foot swelling, leg swelling, thigh swelling, and then another problem can happen. So anytime when you find the swelling come up, we need to eliminate at early. Again, neuropathic pain are very common that now we need to prescribe some medication when the patient develops this kind of neuropathic pain. So in conclusion, I would say that the MSTK is still there, but the successful surgery needed to get a very well balance among 3 cycle technique, anesthesia protocol, and the post-op rehabilitation. And then the real evidence of the NS is just a shorter skin incision and greater knee flexion at early follow-up. And then if you want the better result, you need to address the subacute pain, you acknowledge the post-op inflammation, you balance the activity and pain control, and control the limb swelling. And then you need to address the neuropathic pain. So thank you for your attention.